Hey guys, welcome back to my channel, The ENT Resident. Today we'll be talking about a case which is quite commonly seen in the OPD, and a lot of children will come to you, especially during the season time, and they'll come to you with acute tonsillitis. So we'll talk about what is it, what causes it, what are the different types and pathology behind it, what are the symptoms and signs that your patient will come to you with, how do you investigate, and how do you treat these cases. Okay, you can also now purchase my notes. I have added links in the description. Okay, let's get started with our topic. So, what is acute tonsillitis? So, acute tonsillitis can be defined as the acute inflammation of the palatine tonsils, which may involve the mucosa, the crypts of the tonsil, the follicles, and or the tonsillar parenchyma. And based on what part of the tonsil has been involved, we'll see that there are different types of acute tonsillitis that you could see. Now, to know more about the anatomy of the tonsil in itself, you can check out my other video where I have discussed about the anatomy of tonsil. Okay, so what causes acute tonsillitis? Now, this is a disease that most commonly you'll see that school-going children will be coming to you with the presentation. It can also affect adults as well. What we need to know is this is, however, very rare in infants as well as adults who are over about 50 years of age. So your most common age group that it will be coming to you are going to be school going children, followed by adults, young adults. Now, the etiology here, now this can either be a localized episode or it can also be in association of an upper respiratory tract illness that the patient is suffering. So, you'll have other parts of the upper respiratory tract involvement as well. Or this can even present as just a part of a generalized systemic infection. Now, the most common microorganism that is involved here, then now this is a very common MCQ question that you need to know about, is the most common cause of acute bacterial tonsillitis is the group A beta hemolytic streptococcus, GABHS is what this is known as. Now, the common route of spread of infection is usually through aerosolized microdroplets. And there are other bacteria and viruses as well that are involved with causing acute tonsillitis. So, other than the most common one being the group A beta hemolytic streptococcus, the other bacteria could be Streptococcus pneumoniae, Streptococcus viridans, Moraxella catarrhalis, Staphylococcus aureus, Haemophilus influenzae. And then we have some viruses which involve the Epstein-Barr virus, adenovirus, or the rhinovirus. So that's about the etiology and what are the microorganisms causing this disease and what is the most common bacterial cause of acute tonsillitis, and which is group A beta hemolytic streptococcus. So this is what we need to know here, and the most common age group involved here is the school going children followed by young adults. Now, let's try to understand the pathophysiology behind this disease, and based on that, what are the different types of acute tonsillitis that we have. Okay, so let's look at the first image over here. This is what a normal tonsil will look like. These are all the crypts that you can see, the primary and the secondary crypts in the tonsil. Now, the process of inflammation itself, it starts within the tonsil, and then it is accompanied by some hyperemia as well as edema. And what happens is you know that there are lymphoid follicles within the palatine tonsil. So we know that palatine tonsil forms a part of the Walde's ring. Now, Walde's ring is this protective lymphoid structure which we have in our upper aerodigestive tract, which is responsible for giving us immunity. So we have lymphoid follicles within the palatine tonsil. Now these lymphoid follicles, they start getting converted to small abscesses. And now these small abscesses start discharging in these crypts of the tonsil. So depending on how the disease is progressing, we will classify acute tonsillitis into four different types. So we have images for three of them, and the fourth one we do not have. We'll just talk about it. So the first type that we have over here is known as the acute catarrhal or superficial tonsillitis. Now, what is this? In acute catarrhal or superficial tonsillitis, you'll see that the tonsils are inflamed as a result of a generalized infection of the oropharyngeal mucosa. I mentioned earlier when I was discussing about etiology that this could acute tonsillitis can present as either as a localized episode, or it can even come with association with an upper respiratory illness. So the rest of the oropharyngeal mucosa is also involved. So commonly you'll see that there is acute tonsillitis along with acute pharyngitis present. So that's when we call this as acute catarrhal or superficial tonsillitis. This usually happens because of a viral upper respiratory tract infection. So that's our first type. Now, next we have our second type, which is known as the acute follicular tonsillitis. Now, if we look at the second image over here, this is what an acute follicular tonsillitis will look like. What happens here, as the name suggests, is the inflammatory exudate, which is collecting in these tonsillar crypts. You can see that these are filled with these exudates forming in the tonsillar crypts. They start presenting on the surface of the tonsil. So this is our surface of the tonsil, right? So these start coming out of the crypts and they start presenting as multiple yellowish white spots on the inflamed tonsillar surface. If we look at the first image over here, you can see how an acute follicular tonsillitis case looks like. They look like these yellowish white spots all over. And these are all the spots where the crypts are opening into the surface of the tonsil. So this is what acute follicular tonsillitis will look like. Next, moving on to our third type, we have the membranous tonsillitis. Now, membranous tonsillitis is a stage of tonsillitis which is ahead of follicular tonsillitis. So if follicular tonsillitis keeps going on without being treated for a while, this will convert to form a membranous tonsillitis. So what happens here? You can already see that these crypts were filling up with exudate and they were coming up as yellowish white spots. Now, these yellowish white spots that and the exudation that is coming from the crypts, they start coalescing together to form a whole membrane over the surface of the tonsil. And that is why it is known as acute membranous tonsillitis. You can see in the image over here how this has formed a membrane over the tonsil. Now, a very common question that you face in your vivas as well as in your theory exams, especially in undergraduation, is known as the differential diagnosis of membrane over tonsil. Now, acute membranous tonsillitis will be one of your differential diagnosis of membrane over tonsil. This is a topic I'll discuss in a separate video. You can check it out over there. So that's what acute membranous tonsillitis is. It is one stage ahead of follicular tonsillitis. And the fourth type that we have here is known as the acute parenchymatous tonsillitis. What happens here? The whole of the tonsil gets uniformly congested. So this is this part, the red part that you're seeing over here is the tonsillar parenchyma. So the whole tonsillar parenchyma gets uniformly congested and swollen, and that happens because of the hyperplasia of the lymphoid follicles which are present in the tonsillar parenchyma. And that's what leads to the development of acute parenchymatous tonsil. And as you can see in the image over here, these will look like that as if the tonsils have uniformly enlarged on both the sides and they are very reddish and congested. So these are our four different types of acute tonsillitis based on the progression of the disease. We have the acute catarrhal or superficial tonsillitis, acute follicular tonsillitis, and acute membranous tonsillitis, and lastly the acute parenchymatous tonsillitis. So these are our types of tonsillitis. Now let's discuss how will our patient present to us. So when a patient presents to you, that is what is known as the symptoms. And when we clinically examine the patient, that's when we see the signs. So first, let's talk about the different symptoms. Now, the most common symptom that your patient will come, usually a child will come with their parent to you with, is that they'll complain of a sore throat. And then they'll have difficulty in swallowing, which is dysphagia. Now, dysphagia, like they'll have difficulty in swallowing. Sometimes the patient, if they are very young, very tiny, they may not be able to say properly. So the parent will come to you saying that the child is refusing to eat anything. That is probably because they are having pain when they are trying to swallow the food. So dysphagia, or difficulty in swallowing, is a very, very common symptom that you will see in these cases. And because this is an acute inflammation, one of the primary symptoms over here is fever. Now, fever can vary between 38 to 40 degrees Celsius, and it can even be associated with chills and rigor. And sometimes in young children, they can even present to you with febrile convulsions occurring as a result of this. So, fever is also a very defining symptom over here. Then another symptom that sometimes may not correlate, they can directly come to you with pain in the ear. Now, sometimes they may not have like a prominent like difficulty in swallowing. They can come to you with a pain in the ear, and then when you check the ear, you see that the ear is absolutely normal. Now in these cases, you'll see this is actually a referred pain that is coming from the tonsil because of a common nerve supply that the ear and the tonsil is sharing. So this is known as referred pain in ear. To understand more about referred pain in ear, again, I have a separate video. You can check it out over there. Now, this ear pain that the patient is coming to you with, one cause is obviously a referred pain, but sometimes you'll see that the patient actually has symptoms in the ear as well. When you check the ear with an otoscope, you'll see features of acute otitis media. Now, how does this happen? Acute otitis media is actually a complication of acute tonsillitis. So, when acute tonsillitis has not been treated immediately, what can happen is you can have an ascending infection via the eustachian tube into the ear, and that can lead to the development of acute otitis media. So, when a patient of acute tonsillitis comes to you with ear pain, there are two reasons. Possible reasons behind it. One is the ears are absolutely not involved, and this is just a referred ear pain. And second, it has a complication of acute otitis media in the patient. Next, there are a lot of constitutional symptoms that your patient will complain of. They'll have malaise, they'll have headache, a generalized body pain, and usually this will be more marked than in a case of simple pharyngitis. And lastly, another case, this you can see only in younger adults, that they may complain to you of a voice change. Now, why does voice change occur in acute tonsillitis? This can happen because of accumulation of saliva, because you're not able to swallow properly because you're having difficulty in swallowing and pain while swallowing. So it can happen because of the accumulation of saliva, as well as the restriction of the movement of palate and tongue due to the pain. So these are all the different symptoms that a case of acute tonsillitis will present to you with. Next, let's talk about what are the signs that you will be seeing in your patient. Now, first of all, let's categorize this properly. So, when you look at the patient, on a general examination, you'll see that the patient, especially in a child, they'll have a toxic look and they'll present to you with fever. Then, when you look at the oral cavity and oropharynx, you'll be seeing that there is a coated tongue. Coated tongue is because, like children, because they have difficulty in swallowing, they'll stop having food, they'll stop maintaining the oral hygiene. So the tongue gets coated, and they can even have a foul smell coming from their breath, halitosis. Then, when you check the oral cavity and the oropharynx, you'll see that there is hyperemia of the tonsillar pillars, the soft palate, as well as the uvula. Now, based on the type of the tonsillitis, each of the patient will be looking different. So, if it is a case of acute follicular tonsillitis, as I showed in the picture above, that the tonsils are going to be, let's look at the image again. The tonsils are going to be very reddish and very swollen up, and you'll see these yellowish white spots of pus or purulent material presenting at the opening of the crypt. This will be diagnostic of acute follicular tonsillitis. Then, in a case of acute membranous tonsillitis, you will be seeing a whitish membrane over the medial surface of the tonsil, and this membrane can actually be easily wiped away with a swab. So that's what acute membranous tonsillitis will look like. And lastly, in case of an acute parenchymatous tonsillitis, you'll see that the tonsils may be enlarged as well as congested. They'll be very reddish, and so much so that they are almost meeting at the midline along with an edema of the uvula and the soft palate. And in case of acute catarrhal or the acute superficial tonsillitis, you'll see that there will be a generalized congestion involving the posterior pharyngeal wall as well. So these are all the things that you will be noticing when you check the oral cavity as well as oropharynx. But that does not complete a complete clinical examination. In these cases, you also have to examine the neck. And when you examine the neck, you will be seeing the enlarged and tender jugulo-digastric nodes. These are the primary nodes which are draining the tonsils. So you will be seeing that these are enlarged as well as tender. So these are all the signs that our patient will show you. Next, how do we investigate the case? Now, most of the time, these cases are very like you just make a clinical diagnosis of the patient and you treat the case. But let's talk about in case of some specific investigations in some cases which you may need. So, when you do a complete blood count, you'll see that the patient will be having leukocytosis. This is an acute infection. So, we'll have neutrophilia happening over here. And if this was a chronic infection, you will be seeing lymphocytosis. So we'll have an increase in the total count where we see an increase in the neutrophils. Next, the most common bacterial organism involved here is the group A beta hemolytic streptococcus. So we can do a rapid strep test. Now this is usually a latex agglutination or an ELISA method which extracts the antigen from a swab. Mostly we do this to find the streptococcal antigen. This is a test which is highly specific but less sensitive than culture. Sometimes in cases where the patient is not getting better with treatment, you may need to do a throat swab for culture and sensitivity. And we usually take this swab from the tonsillar area and the posterior pharyngeal wall. Then an ASO titer will show that streptococcal infection which will have an elevated anti-streptolysin O antigen. And a peripheral smear will show if you can do a peripheral smear in case the patient is not responding to rule out agranulocytosis and leukemia, and a monospot test can rule out an infectious mononucleosis case. So these are the investigations required. Mostly we do it in patients who are not responding to treatment. And lastly, let's also talk about what is the treatment that we'll give to the patient. So first of all is the patient needs a lot of bed rest and you have to drink a lot of fluids. Most of the times they'll be very dehydrated, so a lot of fluids is required even though they'll have difficulty in swallowing. Then we'll have to treat the pain and the fever of the patient. So we'll give them analgesics and antipyretics like paracetamol and aspirin. And antibiotics are also started. Now, the drug of choice, especially in case of streptococcus, would be penicillin. Sometimes you'll have a beta lactamase producing hemolytic streptococcus. In that case, you should treat them with a combination of amoxicillin and clavulanic acid. And in patients who are allergic to penicillin, the preferred drug of choice would be erythromycin. So, antibiotic treatment will be continued for about 7 to 10 days. And if the patient it is a severe case of infection and they have come to you at a later stage and they are very ill, like generally toxic look and ill, in that case, you may even need to start intravenous antibiotics. And lastly, you also tell them to do antiseptic throat gargles like betadine gargles or even lukewarm water with salt gargles thrice daily. So that is what our treatment protocol will look like in case of acute tonsillitis. Next, let's talk about what are the complications of acute tonsillitis. Now, if this acute tonsillitis, the infection is not completely resolved, it can lead to development of chronic tonsillitis in the patient with recurrent attacks of acute tonsillitis. So the infection will continue to persist in their lymphoid follicles in the form of microabscesses. So a lot of patients, they'll come to you recurrent attacks of tonsillitis, and ultimately, depending on the number of attacks, they end up being a indication for performing tonsillectomy in the patient. So if you want to know more about what are the indications, what is the paradise criteria of tonsillectomy, I have a separate video where you can learn more about that. Next, acute tonsillitis can also complicate into forming a peritonsillar abscess, to a parapharyngeal abscess, to even a retropharyngeal abscess. Even a cervical abscess can develop because of suppuration of the jugular-digastric lymph nodes. Then, acute otitis media, something that I already mentioned. So, there can be ascending infection causing a eustachian tube dysfunction, leading to recurrent attacks of acute otitis media. So, the patient will come to you, ear pain. Next, especially with the streptococcal cause, the patient can have rheumatic fever. This is very often seen in association with tonsillitis because of the group A beta hemolytic streptococcus. Acute glomerulonephritis is also another such thing, but this is much rarer nowadays. And the third disease that is commonly seen with streptococcus is a subacute bacterial endocarditis. Now, patients who have valvular heart disease and they have acute tonsillitis, they may get complicated by this endocarditis. The Streptococcus species which is involved here is mostly Streptococcus viridans. And there can even be septicemia and internal jugular vein thrombosis. These are the complications of acute tonsillitis. Lastly, let's talk about the differential diagnosis of acute tonsillitis. So we have scarlet fever, diphtheria. Diphtheria also you'll see a whitish patch over the tonsil, but you'll in diphtheria classically you'll see a true membrane compared to acute membranous tonsillitis, which is a false membrane or a pseudomembrane. Then we have Vincent's angina, infectious mononucleosis, agranulocytosis, glandular fever, and leukemia. So that's all for today. I hope you have understood everything in this class. And if you have any doubt, please note them down in the comment section and I'll get back to you. Thank you.